Hi everyone, welcome. We'll get started in a couple of minutes here. Hi everyone, welcome. We'll get started in a few minutes. Please feel free to introduce yourself in the chat. Hi everyone, welcome in. Let's get started in a few more minutes here. I'll just give about one more minute for some more members to join. We can go ahead and get started with introductions as some more participants join. So good afternoon, everyone, and welcome back to Lecture 2 of the Upgrade Oncology Digital Training for Nurses and Clinical Oncologists. Once again, this training is brought to you by Project Pink Blue in partnership with BioVentures for Global Health and funded by the ACT Foundation and the Nigerian Federal Ministry of Health. So we're really pleased to virtually welcome everyone back to today's meeting. And once again, though we cannot all be together in person, I really do encourage you to share some photos of yourself or your colleagues and how you're engaging in this webinar and this training series, so that we can just see the various settings that everybody is able to fit this educational material into their busy work days and their busy lives. And at the end, we like to put together a little visual collage of the submissions that we received. So please feel free to follow up with me via email. I'll put my email in the chat if you'd like to send any photos. And then before starting the presentation, I just want to go over a little bit of Zoom information. So we are in a webinar format today, which means that your videos and your microphones are muted and turned off by default. So if you have any questions throughout the webinar, please submit them to me through the chat box at the bottom of your screen, and I'll be able to provide those questions to our presenter at the end of our session today. We'll have some time set aside for that. Once again, we'll be recording this session, and the slide deck and recording from both today's session as well as last week's session will be sent out to you later this week. So please be on the lookout for that. And then if you have any issues or need any help operating Zoom at any time, please send a private message to me in the chat throughout today's lecture. And then now we have Gloria Uku on the phone as well. Gloria from Project Pink Blue. Would you like to unmute and say a few comments?
Yeah, hello everyone. Thank you so much for joining us. This is the second part of this training series for oncology nurses, and we're so happy you availed us your time today. We're so happy to have you here. My name is Gloria Oku. I am the program coordinator for Project Pink Blue. Project Pink Blue is a cancer fighting organization based in Nigeria, and in partnership with BVGH, funded by ACT Foundation Nigeria. We're bringing you this training, and we hope that this training will go a long way to close the care gap that exists in cancer treatment in whatever part of the world they're joining us from. So thank you, and a very big thank you to Renee for agreeing to be the trainer for this course. And please, go ahead and ask questions you have. Tell us your name in the inbox, like Regina said, and please give us any feedback you have on how we can improve these trainings, on what else you want us to do consequently. Whatever feedback you have, please, we are open to feedback. Just put it in the chat box, and we'll make sure to incorporate it in our next trainings. Thank you very much. So I'll quickly hand over so we can start the training program. Thank you, and happy learning.
Thank you so much, Gloria. And so now it is my pleasure to welcome our presenter for today. Renee Wisniewski works as a palliative care nurse practitioner, providing care to oncology patients at Memorial Sloan Kettering Cancer Center. She's an adjunct professor with the New York University Rory Myers College of Nursing. And Renee graduated from NYU College of Nursing with her Bachelor of Science in Nursing and Master's degree. She studied at the University of Colorado and obtained a Bachelor of Arts in Anthropology. She has published articles on nursing communication strategies and primary palliative care in nursing. And we're so happy to have her here with us today. So Gloria, I'll go ahead and stop sharing my screen, and you should be able to share yours. Thank you so much.
Good morning, everyone from the East Coast of the United States. I think it's afternoon in Africa, where most of you, it looks like, are from Nigeria. And I want to thank Caitlin and Gloria and all of you for being here today and asking me to be here to present about supportive care treatments. It's going to be a pretty dense lecture, and any questions you have, if we don't get to them, I can always address them after the presentation, and I'm also presenting next week as well. So I'm going to get right in and start and share my screen. Okay, so I have no disclosures, and the objectives for today are just to define palliative supportive care, review the 8 domains of quality palliative care, familiarize ourselves with communication skills that can be utilized for some difficult conversations, identify common symptoms and treatment considerations for providing primary palliative care. Please note during this presentation, I do use palliative care and supportive care interchangeably. So in this presentation, they both mean the same thing. In the cancer center and the culture that I practice in, palliative care is often associated with death or end of life, and often is synonymous with hospice. We do a lot of work to try to dispel that myth and inform and educate patients and providers that palliative care can be provided at any time and any stage during the course of a chronic illness. And that can be at the initial diagnosis, or it can be in the middle of a treatment, or towards the end of a prolonged chronic illness. So it's not hospice, it's symptom management throughout the course of chronic illness. And also, palliative care can be initiated while undergoing aggressive treatment. I work at a cancer hospital, and this is especially important to educate our patients and families about. So just to familiarize all of you with the 8 domains of palliative care, we look at structure and process. We can see that it's based on patient and family goals. We discuss prognosis, disposition goals. Is it inpatient? Is it home? And discuss safety. Another aspect of palliative care is the physical aspect. Symptoms such as pain, dyspnea, nausea, vomiting, fatigue, constipation, performance status, medical diagnosis, medications, when to add medications, when to wean them, and how to titrate them. And this isn't specific to oncology, although most of the symptoms are present in oncology, but can be present in other chronic illnesses such as heart failure, diabetes, and dementia. We also discuss and look at the psychological aspects of care. Especially in the United States, we've been focusing on mental health a lot and connecting the mind-body, how our mental health can impact our physical health. Anxiety, depression are very common in people with chronic illnesses. Delirium, cognitive impairments can be a part of the disease process, but can also be side effects of treatments. Palliative care addresses stress, anticipatory grief, coping strategies. These can be treated with pharmacological interventions and non-pharmacological interventions. And also, we look at patient family grief and then bereavement once the patient has passed. Another domain of palliative care is the social aspects of care, connecting with family, friends, looking at the communication, interaction, and support a patient has, and then also helping with caregiver crisis. So it's not only a burden to be the patient, the person with the chronic illness, caregiver distress and burnout is quite prevalent among people who care for people with patients with chronic illness. Spiritual aspect of care is also addressed in palliative care, again, related to the mind-body connection. People's spiritual, religious, and existential health can impact their ability to cope with their illness, the diagnosis, and treatments. It's important to address the hopes and fears of both the patient and the family caregivers, and discuss forgiveness throughout the course of treatment. Palliative care also incorporates cultural aspects of care, addressing language, ritual, dietary concerns, and also communication strategies between families, who receives information and how information is disseminated among the family, and how the patient wants decisions to be made. Palliative care can incorporate care of the imminently dying. It recognizes and communicates with patient family and normalizes the process of dying, and can also help with prognostication. How much longer does a patient have to live? And also, palliative care plays into the ethical and legal aspects of care, who decision makers are and what advanced directives and how they impact patient care. This may be specific to the United States or to Europe, but generally it's important for a patient to have a healthcare proxy. So if the patient doesn't have capacity, we can speak with somebody that the patient has designated to make decisions for them. This is just an overview of palliative care. It's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses. It's the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, such as physical, psychological, and spiritual. So this early intervention and identification is important in terms of assessing a baseline of a patient, and then the assessment component is helpful throughout the course of the patient's disease. We understand that the symptoms, physical, psychological, and spiritual, differ with initial diagnosis and as the disease progresses. Palliative care begins at diagnosis and should be delivered concurrently with disease-directed life-prolonging therapies if that's the patient's wishes, and should facilitate patient autonomy, access to information, and choice. And then also palliative care should be provided by the primary oncology team and augmented as needed by collaboration with an interdisciplinary team of palliative care experts. And so in the United States, I practice as a palliative care nurse practitioner. So that's a specialty, which may be a luxury. This presentation does include primary palliative care interventions that you can use as part of the primary oncology team. So the key focuses of palliative care, again, at a specialist level of palliative care, which I practice at, we treat refractory pain and symptom management. So if the primary oncology team and nursing team is not able to manage symptoms, we are the referral team, the consult team that intervenes. We manage complex anxiety, grief, and existential distress. We assist with conflict resolution regarding goals or methods of treatment, and that can be among families, between staff and families, or among treatment teams within the hospital. We also use an interdisciplinary team approach to support patients and their caregivers. And I want to include, we also support the primary oncology team and nursing staff. Providing care to patients with chronic diseases can increase burnout and fatigue. And so it's important to have an extra layer of support for not only the patients and their families, but also the staff. And it prevents and relieves suffering through the early identification and correct assessment and treatment of pain and other symptoms. So we're just an extra layer of support and assessment for patients, families, and the teams. So I just want to introduce a case study to get us thinking about what palliative care interventions we can utilize. RS is a 32-year-old female who's diagnosed with triple-negative breast cancer, and that was back in April of 2021. She identifies as Catholic. She's married. She lives with her husband and mother in a neighboring state. So she's not in New York State. She's in a neighboring state, so she has to travel for care, and would one day like to become a mother. So at the age of 32, she still has not birthed any children. She's referred to palliative care in June of 2021 for assistance with symptom management. What symptoms can supportive care help manage in this young patient undergoing chemotherapy? I just want to start all of you thinking about, as a 32-year-old newly diagnosed with a pretty aggressive form of breast cancer, what types of symptoms, even before initiating chemotherapy, might this person be experiencing? Physical, psychological, spiritual, and just start thinking about what comes to mind, and also what members of the interdisciplinary team would be involved in caring for this patient. At the hospital I work at, we have chaplains, we have social workers, we have psychiatrists, we have an integrative medicine team. So we do practice interdisciplinary medicine, and these are just some people who may be involved in her care. So again, members of the palliative care team, this is just an example. This is not a comprehensive list. Doctors and nurses, social workers, again, chaplains. At the institution I work at, we do have interfaith chaplains, imams, rabbis, priests, pastors. We have nutritionists who can help guide patients in choosing food that's helpful and can be tolerated. We have physical therapists and occupational therapists to help with modifications within the home. So palliative care doctors and nurses, again, they manage symptoms that are refractory to primary palliative care. They help in assisting when cases are near futility. We treat total pain. I'm not sure if people are familiar with that concept, total pain, so I will define it in the next slide. Palliative care doctors and nurses are also especially trained in communication skills. Two tools that I'll review during this presentation are spikes, which is thinking about the setting, the perception, inviting knowledge, emotion, summarizing and strategizing, and then also the nurse communication tool, which is naming, understanding, respecting, supporting, and exploring as communication strategies when communicating difficult or sensitive information. And then palliative care doctors and nurses also assist with conflict resolution. Again, as I talked about in the previous slide, it can be with families, between staff and families, and among treatment teams. So total pain has actually come to the forefront of especially palliative care over the past 20 years. I'd say it's associated with the early work of Cicely Saunders. She began publishing back in the 1950s, and she started articulating the relationship between physical and mental suffering. And so total pain has been mentioned to include physical symptoms, mental distress, social problems, and emotional difficulties. And what the concept seeks to clarify and articulate is that if somebody's experiencing mental distress, likely physical symptoms will worsen, or if there's social problems or emotional difficulties, mental stress and physical symptoms will be exacerbated. So we can't separate out or parcel out what's going on in our personal life, our social life, our emotional health from what we're physically feeling. And so it's important to treat total pain and not just physical pain. So again, some basic communication skills, and at the end of this, included in this lecture are some communication resources. What we find is that it's important to be clear in what we're communicating to patients and their families, but also be sensitive. And so the spikes communication tool really takes into mind the setting, where we are giving information to patients and their families. ensure privacy, introduce yourself and those who are present for the conversation. It's important to think about who should be present during the meeting, who maybe does not want to be present, and asking and engaging the patient is helpful in understanding. Sometimes there's a pre-meeting among the providers or the interdisciplinary team to assess what the goals of the meeting should be. It's important to be able to sit down and have no interruptions when communicating difficult information or serious information. Very important to figure out who's going to lead the conversation. And also perceptions. So what is the patient and family understanding of the illness and situation? So this is more of an ask, tell, ask. So assessing what the patient and the family understand, asking. So for example, I know you've heard about it from other doctors, but tell me what you think is going on with your cancer. So that gives you a sense of what the patient or family is thinking. And then you can explain to them and then reassess by saying, so what did you just hear me say, or what's your understanding of the information that I just relayed? Also an invitation, how much does the patient want to hear, and ask for permission before disclosing information. So this goes back to the setting and who's present. Sometimes patients don't want to be present when serious information is discussed. Sometimes they defer to a healthcare agent, a family member. And so always ask for permission. How do you like to receive information? Do you prefer details? Do you prefer a big picture? Who would you like to hear the information? Also, K stands for knowledge. Be straightforward, use plain language, not medical jargon. Keep it short and give a warning. I don't like to use the word shot, it feels violent, but give a warning acknowledgement that this may be hard to hear, or I feel badly to tell you, so that the patient knows that there's some serious information that maybe isn't what we had hoped. Again, E is emotion. Silence, nonverbal communication, asking permission to move on, allowing for the patient and the family to process information that you've just disclosed or that you're discussing that can be challenging to hear, especially if it's the first time that the information is being disclosed. So it sounds like this has been frustrating, or I cannot imagine how hard this is for you. Those are some emotional validation starting sentences. And then the S can stand for summarize and strategize. So reassess the understanding of the patient and the family, make plans to follow up, assess readiness to discuss treatment options. For example, I want to be sure you understand that what we have discussed. Can you summarize to me what we have discussed? Or a much simpler way is, what are your thoughts about what we've just discussed? So this is a really helpful tool when you're speaking with the patient or family about serious information. The nurse communication strategy is another tool for articulating empathy. So N stands for naming. It sounds like you're frustrated. It can be helpful in acknowledging what somebody's feeling to validate the emotion, but also to explore further what the patient or family is thinking and understanding. The U again is for understanding. This helps me understand what you are thinking. Think of it as another kind of acknowledgement, but stop short of suggesting you understand. So the U isn't for like you're understanding what they're feeling. The U is more for helping to better clarify what the patient and family are understanding and feeling. R is for respect. I can see that you've really been trying to follow instructions. Remember that praise also fits in here. So I think you've done a great job with this. Oftentimes when patients progress on treatment, there's this idea that they've failed or they've done something wrong or they haven't done enough. And so acknowledging that you see that they're doing everything that they can and they're doing a great job is important. S is for supporting. I'll do my best to make sure that you have what you need. Making this kind of commitment is a powerful statement because it puts you in a team setting with the patient. So it doesn't separate the two of you. It doesn't separate the patient from the team, the medical team. It makes you one team. And then E is exploring. Could you say more about what you mean when you say that? For example, if the patient says, you know, they have, they're hoping for a cure or they're hoping for a miracle, asking what they mean when they say that can really be helpful in clarifying what a miracle looks like or what a cure looks like for them. Words matter. In the United States, oftentimes we think about when we don't have any more cancer-directed therapy or diabetes-directed therapy, there's providers who say capping care or withdrawal of care, or we refer to patients as do not resuscitate. We try to avoid this because it doesn't feel good as a patient to feel like you're not getting something. And so what we try to say is that we're going to continue the current medical care, or we're going to avoid further invasive treatments or interventions that are not in line with patient goals or that are not beneficial in symptom management. When somebody's on a ventilator, mechanical life support, and the family wishes to have the life support removed, it's a palliative extubation, or discontinue life prolonging interventions, goals in line with allowing for natural death, and the family or patient has decided that their goals are in line with a do not resuscitate. So it's just subtleties where the patient doesn't feel like they're not getting something, and that we're still supporting them as a medical team. So I'm going to move along to common symptoms in palliative care patients. And this is kind of the nuts and bolts of supportive care treatments, especially in primary palliative care for nurses and doctors, pharmacists. Common symptoms, I think if you look at this list, hopefully all of you have experienced this in your practice. Pain is often very common, especially in cancer patients, nausea, vomiting, either due to treatments, cancer treatments, or due to the disease process. Fatigue is present in any chronic illness. Again, depression and anxiety, I think it's important to normalize these emotions in patients who have a chronic illness. They're not abnormal. Feeling depressed, feeling anxious is very normal for patients with any diagnosed chronic illness. Shortness of breath, dyspnea can be present depending upon the disease and where the patient is in their disease trajectory. Constipation often presents either due to pain medication or due to the disease process or due to change in physical activity or oral nutrition. Delirium can be part of a disease process, or it can be a side effect of treatments, or it can be a side effect of medications. Spiritual distress, often when somebody's confronted with a chronic illness and they're approaching end of life or have been told that there's no further treatment options, spiritual distress can manifest, or it can also manifest early on in a diagnosis when somebody feels abandoned by their religion, receiving a diagnosis of a chronic illness or terminal illness. Anorexia often present, either due to disease process or treatments. And then insomnia can be related to depression, anxiety. It can be related to medications. It can be related to spiritual distress. And so we'll take a look at each of these symptoms and interventions for primary palliative care. So nausea, vomiting, pharmacotherapy strategies. These are medications that are common in the United States and available. So I know that in the area that you practice in, these medications may look a little bit different. And so there's the drug class, there's the medications, the receptors that they target, and common side effects. I'm not going to go through each of these. I just want to say that we do tend to use not just one drug class. And so we try to target different receptors so that if nausea is being caused by chemotherapy, we're targeting one pathway, but also we're addressing other pathways as well in case there are other pathways of nausea involved in the symptom. We all in New York, in the United States, cannabinoids are starting to become legal for medical use. It is not federally legal, and so each state has their own laws regarding use of medical marijuana. Cannabinoid that is federally regulated is dronabinol, and so that's why it's listed here. Also, benzodiazepine, lorazepam we use often, and I'll speak about that medication a little bit later on. Steroids we use, and so this list will be available to you. Some key takeaway points for the treatment of nausea and vomiting is, when possible, choose a drug that will treat more than one symptom. You want to get more bang for your buck with the medications that you're using, because if somebody's nauseous, likely they're having poor PO intake or not able to tolerate a lot of medication, or they're in pain and nauseous. So, for example, lorazepam, which is listed on the previous slide, it treats not only nausea, it can also treat anxiety and insomnia. So it's an example of using one drug, but getting multiple treatments from it. And some non-pharmacological interventions, consider using alcohol swabs. Patients often find it helpful, especially if they just open up an alcohol swab and sniff the alcohol swab. It can help alleviate nausea. Ginger, candy, tea, or raw ginger can be effective if nausea is present. And relaxation techniques, breathing exercises, visualization, and then also pressure point therapy. There are some acupressure points that can help alleviate nausea, symptoms of nausea. So treatment of fatigue is mostly supportive. And so that's why in primary palliative care, it's important to normalize that fatigue is a part of a chronic illness and aging in general. Encourage the patient to rest when tired. Sleep and rest are okay. Normalize fatigue. It's common to be more tired if you have a chronic disease, especially if it is an advanced chronic disease. And that's also helpful for families to hear, as well as the patient's not going to be able to do as much as they used to. And likely the patient will not be able to ever do as much as they used to. And so normalizing that and reiterating it can be helpful. Encourage the patients to schedule activity when they have the most energy, and allow for periods of rest after the activity. So some people feel really good in the morning, and so spending time with family or going out for an hour or two, and then allowing a rest period after, can be really helpful in managing energy and fatigue. And also, research shows that low impact exercise such as walking, gentle stretching, and yoga can improve or maintain endurance and can improve symptoms of fatigue. And then, if available and safe, pharmacological interventions can include a stimulant such as methylphenidate or Ritalin or dexamethasone. Again, going back to the more bang for your buck, dexamethasone can be used to treat nausea, pain, and fatigue. So it's in palliative care, we start thinking about which medications can treat more than one symptom. So again, here's a list of agents for prophylaxis and first-line treatment of opioid-induced constipation. I went through the drug class, the medication, dosing, and then some tips. I'm not going to go through all of these, just saying that first line treatments are often osmotic agents such as Miralax or Senna to help move stool. We generally don't prescribe a stool softener. We focus on laxation. So some tips for treating constipation: encourage hydration if the patient is able to tolerate fluids. Oftentimes people aren't able to drink as much, and so if we can help remind them to drink, it can help keep liquid in the bowels and help the stools remain softer. And if the patient's able to eat, encourage a high fiber diet with fruits and vegetables. Again, that may not be possible, but if they are able to tolerate that diet. Assess if the patient has access to toilet facilities. Does the patient have a toilet they can utilize? So is the patient able to move to the toilet? Are they holding their stool because they don't feel comfortable going to the bathroom? What's their access to toilet facilities? Encourage exercise if appropriate. Again, going back to fatigue, gentle exercise can be effective in managing constipation and stimulating the bowels. Abdominal massage is a great way to help stimulate the bowels as well. It's a circular motion from the right lower quadrant up across the transverse colon and down to the left lower quadrant. Gentle massage can be beneficial. Like prescription laxatives, if we refer to the previous slide, there's a list of them: oral, suppositories, and enemas based on patients' PO tolerance and what is actually causing the constipation, where the constipation is. It's important to also educate patients and families about posture when toileting. Sitting forward with the patient's arms on their thighs, having their feet raised on a small step stool, allowing relaxation and time for the bowels to open are really effective constipation management steps that don't involve any pharmaceuticals. For patients with severe constipation, fecal disimpaction may be necessary. And then if opioid induced and the constipation is refractory to the laxatives mentioned on the previous slide, there are other pharmacological interventions such as methyl naltrexone or naloxegel. So it's Relistor, which is a subcutaneous injection, or naloxegel, which is Movantik. It's a prescription medication specifically for treating opioid-induced constipation. Sorry. Okay, so treating dyspnea. Again, this isn't necessarily present in all patients and all disease trajectories, but some helpful palliative treatments are positioning, having the patient sit up, increasing air movement via a fan or open window, just so to alleviate that sensation of stale air, using relaxation techniques such as visualization, prayer, music, distraction, taking one's mind off of their symptoms of dyspnea. Opioids are the gold standard for treatment of dyspnea, especially at end of life. Low doses of morphine, if available, with the goal of slowing down the respiratory rate. Oxygen. Supplemental oxygen can be therapeutic. It can help people feel like it's easier to take a breath. This is also helpful to discuss in terms of patients' goals and availability. So some patients and providers think of oxygen as a slippery slope to higher levels of interventions, but low oxygen settings, if in line with patient goals, can help alleviate symptoms of dyspnea or lessen symptoms of dyspnea. Antitussives can be helpful if dyspnea is associated with a cough. Anticholinergics such as scopolamine, which is a patch, can help if there's secretions. And then lorazepam can help reduce anxiety, which is often a component of dyspnea. If it's hard to breathe, we start to feel anxious. And again, that lorazepam can help with multiple symptoms, not just one symptom. So it's a medication that we often use to treat multiple symptoms. And then diuretics, bronchodilators, inhalers, corticosteroids, and discontinuing any IV hydration can also be beneficial. Strategies for managing or treating depression and anxiety. I didn't go into a lot of the medications for treating depression and anxiety. I wanted to focus more on supportive measures for treatment of anxiety and depression, because it can get a little too specialized, and medications for depression and anxiety can take a long time to work. So it's helpful if you're using supportive measures and normalizing. Again, anxiety and depression are common symptoms in patients and families facing life-threatening illnesses. Screening for depression and anxiety at each encounter, listed some of the screening tools, is important, especially in getting a baseline understanding of what the patient is feeling. So on initial presentation or initial meeting, screening for depression and anxiety, and subsequent meetings. In the United States, patients with diagnosis of a terminal illness have a significantly higher risk and rate of suicide. So that's also important to recognize when treating patients with terminal or chronic illnesses. Encourage patients to maintain a normal sleep-wake cycle. Encourage gentle exercise, movement. Utilize members of the interdisciplinary team, including social work if available, psychology, psychiatry, chaplain, spiritual support, anybody that the patient feels comfortable with talking with about their emotions and how they're feeling. Nurses often take on this role as well, where patients or family disclose their hopes and their fears to nursing staff. Medications can be beneficial, but vary depending upon prognosis and diagnosis. And for patients with prognosis of weeks, consider a psychostimulant like methylphenidate, Ritalin, if depression is the main symptom that the patient's experiencing. Duloxetine or venlafaxine can also be utilized, especially when neuropathic pain is present. It's that concept of using one medication to treat multiple symptoms. And when polypharmacy is present, consider citalopram, acetalopram, or mirtazapine for treatment of anxiety or depression. And then if patient has insomnia, nausea, or anorexia, consider the use of mirtazapine if available. Again, it's the concept that one medication can treat multiple symptoms. And then delirium. Non-pharmacological interventions are highlighted because it should be the primary focus of delirium is intervening with non-pharmacological interventions. Reduce or increase the sensory stimulation in the environment as needed. So some people may need the blinds opened or the shades open to let light in so that they're aware that it's daytime, or you may need to decrease noise or keep the environment darker if stimulation causes more distress. It's helpful if relatives and friends can stay by the patient. Familiar faces, familiar voices can be really helpful in reorienting and calming the patient down. Also, frequent reminders of time, sorry, that's a misspelling, time and place can help with reorientation. Use of assistive devices, glasses, hearing aids, canes, walkers, anything that the patient needs to get by can help with delirium. And then treating the underlying cause, for example, if it's elevated sodium or calcium or low glucose or low oxygen, treating that can help improve delirium. Some pharmacological management, Haldol. We utilize Haldol for delirium, especially at end of life, and we try to avoid benzodiazepine as it can cause worsening of delirium and agitation. And then treating spiritual distress. I think over the past 20 years, with better understanding and study and research about total pain, we in the United States have started to understand the role of spiritual distress in total pain symptoms. And so utilizing chaplains and social workers to help with treatment of spiritual distress and addressing spiritual needs, including the need to finish business, so forgiveness, reconciliation, or life review for meaning, involved in control of their care plan, so helping include patients in medical decision making, where they're going to spend their last days, and helping to educate them about what options are available to them. And also maintaining a positive outlook by utilizing spiritual strengths and personal resources to keep an open mind and live in the present. And then also address sources of spiritual distress. Are patients fearful of death, the afterlife, separation from loved ones, pain and suffering, and not leaving a legacy? Are patients fearing loss or grief, loss of independence, mobility, loss of life, loss of control, or are other negative emotions coming into play, such as despair, anger, frustration, or helplessness? And so it goes back to those communication skills of naming what people are, what you hear somebody's saying. I hear that you're feeling anxious. Can you tell me more about that? What's causing that? Or I hear a lot of fear. What are you afraid of? And that can help treat symptoms. Treating anorexia, which is also present, especially at later stage of chronic illnesses, address any reversible problems that exacerbate anorexia, including pain, breathlessness, depression, ascites, nausea, vomiting, constipation. So again, addressing just underlying problems that are reversible. Treat any oral problems such as dry mouth, ill-fitting dentures, ulcers, thrush. I always look inside a patient's mouth just to see what's going on in there, if there's anything that's causing them not to be able to eat. Manage delayed gastric emptying, for example, due to local disease or autonomic neuropathy that's causing early satiety and vomiting of undigested foods. Nutrition can be really helpful in assisting in strategies for oral intake. Treat fatigue, which is common and associated with anorexic cachexia syndrome. So small, frequent, high-calorie foods that are accessible to the patient and caregiver can also be encouraged. And then address patient and caregiver concerns about the importance of providing nourishment. Often, I come from a large Italian family and food is love. And so if somebody's not eating and you're being provided with food, it's this, often families feel like they're not doing enough and the patient's gonna die because they're not eating. And so really educating patients and caregivers about food and intake and calorie, energy requirements in chronic illness is important. And then encourage patients and their caregivers to focus on enjoying food, not how much food they're consuming, but enjoying the food that they are consuming and the social interaction associated with eating and drinking. So the patient may not be able to eat and drink everything or all that much, but If they're able to tolerate something, enjoy that something. Again, going back, educate and normalize that a gradual reduction in oral intake is a natural part of the illness that can not be emphasized enough or reiterated enough to patients and families. And then some pharmacological management, steroids, dexamethasone, for example, can help improve appetite. Progestogens and prokinetics can also help with appetite and stimulate appetite. Insomnia is often a symptom that patients with chronic illnesses experience. Helping to maintain or encouraging a normal sleep-wake cycle is beneficial. Avoid long daytime naps, alcohol and caffeine. Relaxation therapies prior to bedtime are helpful. Muscle relaxation, guided imagery, breathing, and then stimulus control. Avoid reading, watching TV, or using the bedroom for any other activities if possible. Gentle physical exercise, again, that's a prevalent theme throughout these supportive treatments. If a patient's able to do just simple stretching, walks, that can be helpful in just maintaining a normal sleep-wake schedule, constipation, fatigue. And then address spiritual and existential concerns, which can cause insomnia. All nurses, staff have to work the night shift, and anxiety, the thoughts that penetrate an inpatient patient's mind with a chronic illness often prevent them from sleeping. I've had a lot of conversations with my patients at night about what their fears are and what they're anxious about. And so just talking and addressing them during the day so that there is some peace in the mind so they can go to sleep is helpful too. Some pharmacological management. Here's some just medications, over-the-counter remedies. I'm not sure if they're available. Melatonin we use quite often just to help reset the sleep-wake cycle. Lorazepam can be helpful as well. I didn't mention it here. And then antihistamines we can use as well. Olanzapine we used for sleep, for anxiety, delirium sometimes, and then nausea, vomiting as well. I'm going to skim through treating pain with opioids because next week I am going to be discussing pain management in adults. And so I didn't want to go too in depth in this, but here are some opioids listed to treat pain in cancer patients. And then some non-opioids as well. You'll have access to this. Again, more non-opioids. More non-opioids that we utilize. And then some key points or take-home points in treating pain. So especially if treating pain with opioids, it's important to address the side effects. Constipation is number one. A person does not become tolerant to constipation, so you have to have them on a regimen, a bowel regimen, if they are on opioids. Nausea is a side effect. Just educate that it can be present, important to have a little bit in your stomach, and you can prescribe antiemetics or utilize antiemetics if needed. Opioids can cause sedation. That's why we utilize long-acting and short-acting. Long-acting gives us more sustained pain relief, and short-acting is for breakthrough pain only. Important to address energy management and timing of taking pain medication. Opioid neurotoxicity, that's myoclonus or hyperalgesia. If myoclonus is present, you can use lorazepam if available. If not, we usually rotate to a different opioid if possible. Opioids can also cause delirium. Assess if there's any other reversible causes. Review medications for polypharmacy or interactions. And then in this case, we utilize Haldol. Other So sedation, sorry, urinary retention, respiratory depression, and pruritus, rotate opioid if possible. So just revisiting our case study, RS completed her chemotherapy, radiation, and surgery. 6 months have passed, and unfortunately, her scan showed she has progression of disease in her bones and lungs. She's experiencing back pain from her metastasis, peripheral neuropathy from her chemotherapy, dyspnea due to lung metastasis, and emotional distress because her oncologist recommended against becoming pregnant. She's questioning, where is God and why is he punishing me? Which supportive care treatments can you recommend to RS? And so this is just a question based on the presentation for you to kind of think about. And she's a common patient that we take care of and help assist primary teams with caring for. Here's a list of the communication resources in addition to the spikes and the nurse. Vital Talk is free. Most of the Hospice and Palliative Nurse Association is online. Most of these are free resources that are available online. Here are the resources I utilized to prepare this presentation, and just wanted to do a palliative care quiz. So these are true or false questions. First question, palliative care can be provided at any time and any stage during the course of an illness. True or false? You're not being graded, so you can write down your answers. Number two, palliative care can be initiated while undergoing aggressive treatment. True or false? Three, it's recommended to try to use a medication that treats more than one symptom. Number four, it's important to make statements that articulate empathy. True or false? And last question, members of a supportive care team include but are not limited to doctors, nurses, pharmacists, physical therapists, chaplains, and social workers. So all the answers are true. So hopefully you were able to get them correct. I really appreciate your attention throughout this presentation, and hopefully there are some questions that I can answer. So I'm going to stop sharing and see if there's some questions.
Thank you so much, Renee. That was really wonderful presentation. I'm so happy you could be here with us this afternoon. Let's see, we have one question in the Q&A so far, but just as a reminder to everyone, if you have any other questions, please add them to the Q&A or the chat, and I'll ask them to Renee. So we can start with one that we have received so far, which is they're asking if it's always the case that patients that are on opioids, especially oral morphine, end up with constipation, or are there any exceptions to this rule?
So in my experience, most patients experience constipation if they're on oral morphine at some point. So it may not be initially, it may be that after several weeks of taking oral morphine, they develop constipation. As a general rule of thumb, if somebody's prescribed an opioid, we prescribe them laxatives or have them take laxatives daily. If they're having diarrhea, we hold the laxatives.
Thank you.
Yeah.
Let's see, the next question. I'm not sure if you'll be able to answer this one, but I'll just pose it. It's a bit large, but asking about some key signs and symptoms of breast cancer. Is that maybe something you can address briefly in your experience?
So I did provide, I was an oncology nurse practitioner for breast cancer population for 2.5 years in the outpatient setting. So I can try.
Oh, so that is the question. The question I think is asking kind of broadly for just some key signs and symptoms of breast cancer.
Oh, perfect. Okay, that's great. So in early stage, so generally mammograms are recommended for women 45 years and older or 40 years and older annually. So breast exams, if there's a nodule or suspicious nodule or change in breast appearance, having that investigated and going to a medical doctor is recommended for ultrasound, mammogram, MRI imaging to assess. If it's late stage breast cancer, so metastatic, signs and symptoms would include pain, and you can also have breast cancer generally metastasizes to the bone, the lungs, the liver, the brain. And so any symptoms associated with dyspnea, bone pain, nausea, vomiting, personality changes, abdominal pain, especially in the right upper quadrant, are things that need to be investigated.
Thank you, that's great. Let's see, next we have, so the next question is about preventing neutropenia, and that we actually will have an upcoming session specifically on neutropenia later in this series. So if you don't mind, maybe we can save that question for that lecture. That'll be in a couple of weeks. Thank you for that question. And then let's see, next up we have what can help. Okay, so with difficulty of breathing when managing an end-of-life patient. So I know you touched on that a bit, maybe just an overview of that again quickly.
Yeah, especially at end of life, dyspnea is a symptom of end of life, and so you'll see breathing changes. Often a patient will have increased respiratory rate, and we treat increased respiratory rate with opioids. Opioids are the gold standard. We want the respiratory rate to slow down. And so that's the side effect of the opioids that we encourage. We usually start with low doses of opioids. So morphine, if it's IV form, 0.5 milligrams IV. You can do it, based on how rapidly the symptom reappears. So if it's, it can be Q 30 minutes, it can be Q 1 hour, however long the morphine lasts. And then we dose escalate based on response to the medication. We don't worry about sedation with treatment of dyspnea end of life because we usually utilize short acting opioids. So we know that with short acting opioids, the side effect of sedation will wear off. And we also know that at end of life, there's a separate process going on that's causing the patient to be sedated separate from the medications that we're giving. So I think one of the challenges as a provider of end-of-life care is explaining to the patient or the family mostly, because usually the patient isn't conscious, that what you're seeing, the patient not being able to engage or talk isn't from the medication. It's a separate process where the patient is dying and we're giving the pain medication, not for pain, but symptom management of shortness of breath, because that increased work of breathing can actually tire the patient out more and may actually shorten the patient's life because they're working harder to breathe. And so education about opioids at end of life is really, really important, I think, around the world. And we encounter this a lot in the United States as well, that people are hesitant to have their family members receive opioids to treat dyspnea at end of life, but it is gold standard. And we start low, we go slow, and we escalate as needed to treat the symptom with short acting opioids.
Great, thank you so much. Let's see, looks like we have two more questions. The next one is on, so one of the classes of drugs you mentioned was cannabinoid. Is cannabis oil okay to manage insomnia and stimulate appetite?
That's actually a great question. I don't feel that I have enough information or research available. We've actually just started doing more research in the United States about the effects or the medical benefits of cannabinoids. Dronabinol has been utilized to To treat anorexia, in my personal experience, I find that the patients that I prescribe it to, it makes them more tired. And so I find that dexamethasone or mirtazapine or Ritalin helps with stimulation of appetite better. In terms of insomnia and anxiety, I have seen patients respond really well to cannabinoids. And then I also think that like CBD oil topically for some pain symptoms, patients have reported anecdotally that it's beneficial for them. I don't have enough research to say that to really verify that these are effective treatments, but there is more research coming, and I think it's exciting to have alternatives to opioids to treat symptoms or prescription, medications with many side effects. And so I think one of the things that we are excited about is that the side effect profile tends to be a little bit lower in cannabinoids, and so there may be a role for them in the future for insomnia, for anorexia, for pain management, but more information is needed.
Excellent, thank you. We have a few more questions are coming in now. So one's actually in the chat. Oh, actually, they just added it to the Q&A. So if a patient has agreed to a DNR, but the relative or caregiver thinks otherwise when the patient is arrested, what should the provider do?
That's fantastic. I generally, I make sure that we have to have a healthcare proxy in the United States, and a healthcare proxy is somebody who makes decisions for the patient if the patient's not able to make decisions for themselves. So we have conversations with the patient and their healthcare proxy about a do not resuscitate order, so that it's not just an exclusive conversation between the doctors, providers, nurses, providers, and the patient, so that everybody's on the same page. Once the patient has elected to have a DNR order for themselves and they're deemed competent, that order generally can't be rescinded unless the patient rescinds it themselves. There are complications where there are family members who do seek to want to rescind it. If they're not the healthcare proxy, they don't have a say. And so for us in the United States, there is this clear kind of legal baton where if you're not a healthcare proxy, you don't have a say. And we as medical providers only listen to the patient and the healthcare proxy. If the healthcare proxy does want to rescind it, it is a case by case discussion. For example, if they want to rescind it for an elective procedure that may reverse the process that's going on, the provider who's performing that procedure may rescind the DNR order for that specific procedure and then reinstate it after the procedure is completed. So there are kind of nuances for the DNR order, but generally if a patient has elected to have a DNR order or their healthcare agent has elected, no other family member has a say. Thank
you. And then the same participant has asked a second question, which is, how do we know if the patient is addicted to an opioid, knowing that that can be a common side effect? So I actually don't list addiction as a side effect. Addiction is how we're starting to think about it is addiction is a disorder. And so there are, I do risk assessment screenings for patients to assess if they are at risk for opioid use disorder. Generally in patients who have metastatic cancer, late stage metastatic cancer, they're using the opioid to treat the pain. Sometimes there is a component of chemical coping, which we do address, and that's the assessment tool that's really helpful in treating anxiety, depression. Oftentimes people will chemically cope when anxiety or depression are present. And so getting an initial assessment on a patient's mental health can be really beneficial, tracking throughout their disease trajectory. And also just asking the patient, like, what are you using this medication for? Can be really helpful. Most patients are pretty self-aware and that like they're not in super pain, they may be in total pain, like they're using the pain medication to treat
their emotional distress, their spiritual distress, and their pain. So addiction in metastatic patients, the incidence is very low because they do have pain symptoms. However, there may be a component of chemical coping, and in that we really pull in the interdisciplinary team and really assess what symptoms we need to treat with different medications or different interventions. In terms of early stage, we try to assess and use non-opioid interventions once we see a decrease in disease burden. So for example, if the chemotherapy is effective and disease is shrinking or there's no evidence of disease, there's no need for opioids. We treat pain with non-opioids. And if there is a component of addiction, we address it. Refer to addiction specialists. We taper off. We don't prescribe opioids. In the United States, we have an opioid, it's called iStop, where we check to see if any other providers are prescribing opioids. It's a national registry. And so we communicate with other providers and really pull in interdisciplinary team members to help treat and support those patients. But initially, the most important step that I take is doing an assessment to assess a person's risk of opioid use disorder.
Excellent, thank you. Let's see, two more. Why would you withhold IV hydration in managing dyspnea?
So it can contribute to fluid overload. So if a patient has ascites, like ascites, or they have like atelectasis, or their end of life, discontinuing IV hydration can actually help ease breathing because you're not contributing to that third spacing. And I should have clarified that stopping IV hydration is more at end of life or later in the trajectory of the chronic illness.
Thank you. And then the final question in the Q&A. For a patient with breast cancer on hormonal drugs, tamoxifen tablet, 20 milligram daily, for how many? For how many years will they be on it? I don't know if that if I asked that correctly.
That's a great question. So I think the guidelines, ASCO guidelines, are the most up to date. When I was practicing in breast medicine, and that was about 4.5 years ago, the guidelines were 5 years for tamoxifen. However, there was research being done to look at where 5 years versus 10 years, which had improved benefit survival rate. And then they were also looking at 7 years. And so I would say refer to ASCO guidelines to see the most up-to-date recommendations for tamoxifen daily. That's the best, most up-to-date guidelines, ASCO, and I can provide that website to you all as well.
Excellent, thank you. Well, those are all of the questions that we have. So thank you so much, Renee. That was a really excellent presentation. There's been lots of great feedback in the chat, and I echo all of that. It was really informative and wonderful, and we're really happy to have had you here for this lesson. And you will be joining us again next week as we'll be talking about pain management. So Gloria, is there anything you'd like to add before we sign off? Okay, well, thank you all so much for being here, and we will see you next week at the same time. And once again, I will be sending out the recording of today's lecture, as well as the recording from last week's lecture and the slide decks for both lectures later this week. So please feel free to follow up with any questions, but otherwise we look forward to seeing you all next week. Thank you again, Renee.